So for this next session, it'll be a little bit different than our previous sessions. Focus will be on hemoglobinopathies. And namely, we'll be talking about haploidentical transplant for hemoglobinopathies, including sickle cell disease and transfusion-dependent thalassemia. I do have a brief introduction because it is a change of pace. Both for sickle cell disease and for thalassemia, they're both associated with significant morbidity, early mortality, and require lifelong medical management. Shown here on this very nice graph are interventions that have been revolutionary for individuals with sickle cell disease, primarily in the United States. Life expectancy has changed dramatically after establishment of the National Sickle Cell Control Act and the establishment of universal newborn screening, the use of preventative penicillin, and the application of disease-modifying therapies, including hydroxyurea, as well as transfusions, chronic transfusions for stroke prevention. In 2019, new medicines like voxelotor and crizanlizumab became FDA approved for disease modification. And separately, what we are most interested in, stem cell transplant became a curative potential in the 1980s. And just in the last decade, we're now seeing gene therapies become a reality. Similarly, for thalassemia major, cause for mortality has changed significantly with improved supportive care, including safer processing of blood products, chronic transfusion protocols, as well as an improved understanding of risks associated with iron overload. Novel technologies, including MRI scanning, oral chelation therapies, have changed iron overload management. And similar to sickle cell disease, stem cell transplant became a potential curative measure in the 1980s, gene therapy in the last decade. And so advances in myeloablative matched sibling donor transplant for both sickle cell disease and thalassemia have resulted in excellent disease-free survival, over 90%, and very high GVHD-free survival, especially in our youngest of patients in youth. So matched sibling donor has really been a gold standard for curative therapies for a while now. Ex vivo gene modification of hematopoietic stem cells using gene transduction or gene editing approaches have become a reality, like I said, in the last decade. And we now have 2 products approved outside of clinical trial for both sickle cell disease and thalassemia. And so here I've outlined, hopefully what will stimulate a great discussion later, but current accessibility of therapies with curative potential. So matched sibling donor allogeneic transplant remains the gold standard. However, only 5 to 20% of individuals will have a matched sibling donor. And so attention has really, in the recent years, turned to improving alternative therapy approaches. For thalassemia, down here on the bottom, transfusion dependence is a universal indication for potentially curative therapies. And this includes matched unrelated donors. Outcomes are quite well. However, very high-risk allogeneic donor transplants have typically been explored only on clinical trial. Notably with gene therapies, we are currently limited to treatment of beta thalassemia genotypes. And alpha thalassemia, currently we don't have a gene therapy treatment approach. In sickle cell disease, allogeneic transplant outside of matched sibling donor has mostly been limited to individuals with severe sickle cell disease and enrollment on clinical trial. Notably for children, my particular interest, severe disease has primarily meant overt stroke or history of stroke. And gene therapies, they, while successfully ameliorate morbidity due to recurrent vaso-occlusive events, they mostly have excluded individuals with neurovascular complications of sickle cell disease. And so we need approaches, that are going to expand access to potentially curative approaches to both of these diseases. So in order to ignite a conversation about haploidentical transplant, I'm going to invite Selim Corbacioglu from Germany, professor of pediatrics, chair of pediatric hematology, oncology, and stem cell transplant at the Children's Hospital Regensburg, Germany, to come and talk about alpha beta T cell deplete haploidentical transplant in both sickle cell disease and thalassemia.
Thank you, Tammy, for this kind introduction, and thank you so much, Alicia, for this invitation here. It has been a great meeting so far, so I hope I can add a little to this. These are my disclosures, and I think the warm-up was working well. I might add a little details here and there. I mean, we have these 2 diseases most prevalent all over the world. It's important to understand that we have more than 300 mutations that are leading to a complete abrogation of the transcription of the beta chains. On one side, we have a single point mutation in all patients, leading to a disease with a very different phenotype depending on the epigenetic variations in the patients. And I think this is important with regard when to treat these patients and when to approach them for curative options. Whereas one disease, TDT, has a highly predictable course. You transfuse them, you try to chelate them, and eventually they are collecting their secondary complications due to iron overload. On the other side, with sickle cell disease patients, you can have devastating vaso-occlusive crises in early infancy, and I think that the differences here is pivotal with regard to, again, when to approach these patients for transplant. So when we start with TDT, we have seen a similar slide before. There's a significant improvement with conventional care up to deferrasirox in 2003, and the curves, of course, were not adapted yet with the addition of luspatercept. But nevertheless, the overall survival, despite optimal care, has not reached yet the general overall population, as you see it here for Italy. Sickle cell disease situation is fairly similar. We have a significant improvement over the last 50 years with preventive measures, education of the parents, antibiotic treatment, and so on and so forth. But again, as Michael de Bon nicely showed, even in America, where the disease is prevalent enough and the experience in the centers is good enough that these patients receive optimal conventional care, the life expectancy is shortened. So to make a long story short, I think both patient populations have an absolute indication for a curative approach. Now, when we look at the transplant activities within the EBMT, we see two things. Number one, we have this dip here that is reflecting the COVID crisis, telling us the stories that non-malignant diseases are put on the back burner when the ICU is needed for all kinds of other transplants and for COVID patients. But most interestingly is this curve. It's like the Sleeping Beauty is awakening here. That means that there were sickle cell patients not being considered for transplant by the adult physicians, and it's just starting in the late 2000s, 18s and 19s, where suddenly these patients are now being approached for transplant and for a curative option. Also important is this table here with the outcome data, mostly matched sibling and mud donor transplantation for sickle and TDT, adult and children, and this 2-year overall survival is kind of the benchmarking for all the alternative treatment options that we have. And what I always find interesting is that we're doing thal transplants for now more than 40 years, 50 years almost, and the outcome is still surprisingly poor with 84% in adult thals, 92% in children, whereas in the sickle population, the outcome is significantly better, considering the patient's diseases that they come in with to transplant. And one of the explanations might be that since we started later to transplant these patients, we of course have different, more modernized approaches, and that's why the non-relapse mortality might be impacted here. It's a question that I cannot answer at the moment, but there is a difference, and I would have expected it vice versa. Now, with regard to sickle cell disease, there's a major difference compared to all the other transplant indications, which is number one, that age is a significant factor with regard to event-free and overall survival, and in particular for chronic GVHD. And I consider sickle cell disease not as a hemoglobinopathy, but rather a disease of systemic vasculopathy, where you have a high-pitched activated endothelium that is the catalyst for all kinds of post-transplant complications. And we have this nice slide of Enrique Carreras that we designed for VOD and PRESS and engraftment syndrome and capillary leak and whatever. All this taking place at the endothelial level. And I think this is a pivotal part with regard to transplant-related complications in this population that is age-related and that is allo-related. So, for example, comparing TDT and sickle cell disease, we don't see a difference in the TDT patients if you use a mud donor or a matched sibling donor. Here, there's a significant difference. So matched sibling is not mud, and interestingly, the cutoff is very young, 15 years of age or 13 years of age, respectively, with regard to the different outcomes. And I think this is important when we consider a matched sibling donor transplantation as standard of care, approaching a 25-year-old patient with the possible chronic GVHD incidence of 20%. And I think this is one of the aspects where a haplotransplant, in particular, T-depleted haplotransplant, comes into the picture of being competitive. So what's the background? Of course, we have the tradition of doing alpha-beta T-depleted transplants for more than 20 years in Germany in particular, or in Europe. We have, of course, an ubiquitous donor availability, including haploidentical donors from alternative parents. So we have done transplants with step-siblings with a different father. They work just as well. It's a fairly safe, established, and efficient curative treatment approach in many other indications. We have a very fast hematological engraftment, as you will see. We have an acceptable immune reconstitution under the protection of gamma delta replete grafts. And of course, the most important aspect that we have to consider in non-malignant diseases such as TDT and SCDs, we have an expectedly low risk of acute and chronic GVHD. The risks of that approach, there is the risk of graft rejection, less that of a graft loss. I think that's a different mechanism. But nevertheless, we have, of course, a higher risk of viral infections and reactivation in this setting. Now, this is the approach that we are using now unchanged for more than 13 years in Regensburg for this setting. And I'll show you first the data on TDT, whereas we started a sickle cell program about 6 years earlier. The conditioning regimen is ATG graph-alone, and we talked about ATG a lot, and I think it is pivotal because if we replace the ATG graph-alone with thymoglobulin with a longer half-life, we would probably see much more graft rejection here. The conditioning does not differ much between matched sibling and haplotransplants. The only exception is the placement of the graph-alone up front in the haplo setting versus the classical -1 to -3 in the matched sibling setting. We use the FTT approach with treosulfan, I think being an important partner here. You're talking about reduced intensity or MAC. I think the question is rather to ask a reduced toxicity and not intensity. So if I have a very low toxic regimen, I can have a myeloablative approach, don't have to deal with mixed chimerism or anything. And I think this is a very nice approach. And when we look at the data of the EBMT registry again, we have a very unique example of how transplant physicians are approaching this, because we can have about 95 different conditioning regimens for one entity, whereas here we see that there's a very unanimous approach to use the FTT conditioning for hemoglobinopathies. And I'm very happy that we see that, because it is tough to compare anything without having any harmonization here. Treosulfan is nice because it has a low endothelial and epithelial toxicity. We basically do not observe much of mucositis, no VOD in these patients, and treosulfan basically does not pass the blood-brain barrier. So in particular for the sickle patients, the risk of PRES is significantly lower here. Important is also that we have a very delicate interplay between conditioning, ATG, and post-transplant immunosuppression. So we use MMF and tacrolimus post-transplant for about 6 months in the matched sibling setting and longer for the haplo setting. And we wean the drugs according to chimerism and split chimerism analyses in those patients. We do an exchange transfusion for the sickles, of course, only prior to transplant to avoid chemotherapy-related vaso-occlusive crises and during surgery, but otherwise the conditioning is exactly the same. So no other pre-treatment for the TDT patients, but this one as we see here. So this is the setting that we have in place for the TDT patients. We have done 13 haplo patients with an adequate follow-up. Age range is between 2 and 23 years, so we are in between the normal age range in these patients. Pesaro class 2 and 3, so some advanced stage patients in there, mostly alpha-beta, in the early days also CD3, CD19. We have a follow-up now of 39 months in these patients, 100% overall survival, 93% disease-free survival. So one patient lost his graft, but we think that has rather to do with the graft itself, because we see issues with the donor here, and that's something that we have to evaluate. We have a median chimerism of 100% in the haplo setting. We have excuse me, an immune reconstitution At day 131 with over 200 CD3 positive cells per microliter. We have seen some viral reactivation, but in this setting, no viral disease. And I think it's important to keep in mind that this is a patient population that we started to do about 6-7 years ago, and instead of the haplo that we have done in the sickle patients that you'll see in a minute. Acute and chronic GVHD, we've seen some acute GVHD grade 1 to 2, which is basically a couple of days of erythema that can be treated with steroids for a couple of days, and that's about it. No grade 3 to 4 acute GVHD, and only mild and moderate chronic GVHD that is waning at around day 180 post-transplant. And we have not seen any severe chronic GVHD in all the patients. So for sickle cell disease, the situation is slightly different. We have now included in this series 29 patients, median age 18 years, so slightly older. Again, a mixed population with mostly alpha-beta CD19 depleted grafts in 20 of the patients. This is the overall disease-free survival with a follow-up of about 55 months. We have a day of engraftment of day 17. Again, we gain about 2 weeks of engraftment in these patients, and compared to the gene editing trials where we have another 10 days where these patients on the floor. We have a median chimerism of about 98%. And we have seen some viral reactivation, and of course we have seen fatalities with CMV and then HHV6, in particular in the early days here. Acute and chronic GVHD, again, no grade 3 or grade 4 acute GVHD, and also no chronic GVHD. And this is what I meant before. There's a learning curve here. I think the major difference is that we used the letermovir prophylaxis in those patients, and after 2019 we just lost one patient that was complicated in the haplo setting, and in starting 2020 we have no more patients that either rejected or had GVHD or lost their graft or anything. So this is, in our hands at least for now, a fairly safe and stable treatment procedure at this time point. And with the availability of virus-specific T cells, I think we are safe of these complications for the future. This is an important slide. Again, this is the red herring for all those diseases. If you wait too long, you see increasingly GVHD, you see increasingly neurotoxicity, so we should go for transplant and for curative options as early as possible. And based on the data I presented, actually in a pilot series of 17 patients, we are now engaging in a prospective phase 2 trial to assess non-inferiority of a haploidentical alpha-beta T-cell depleted stem cell transplantation in patients with sickle cell disease for those with no available donors. So if you have a matched sibling donor, you're stratified in the matched sibling donor arm. You receive a bone marrow graft with the conditioning as you see here, and an immunosuppression of about 6 months. The ATG dose is lower, so 3 times 10 instead of 3 times 15 for the haplo setting. The immunosuppression is maintained for about 6 months, for about 9 months, mostly for the alpha-beta setting. The primary outcome parameters is a composite endpoint, is GVHD-free and disease-free survival, and we are looking at about 210 patients to enroll in that trial. The trial started in the COVID period, so we had a pretty long lag time now with enrollment, but we opened now 16 centers in Germany and Austria, and are opening next week 2 centers in Switzerland, and in the coming months 8 centers in Italy and Denmark and Sweden, and we might open at least 4 centers also in Canada, depending on the availability of the drugs. And the trial is supported by Miltenyi, Medag, and Neovi, who supply us with the medications and the T-cell depletion procedures. And we will see what the trial will show. And this is a slide that Adetola gave me and that he presented at ASH. And I think when we look at the different treatment options post-Cy on the left-hand side, then the gene therapy, gene editing approaches, I added the haplo approach. I think the outcomes are pretty much the same. I mean, the lentiglobin and CRISPR approaches are under very meticulous auspices of including patients. We had a hard time to enroll patients in these trials. And I think when these drugs are out there as a licensed drug, we might see a real-world adjustment with regard to outcome and complications. And I think important, of course, is here the price range where you can basically cure 10 patients with a haplo approach versus 1 patient with a lentiglobin approach or the CRISPR approach even. And I think the benchmarking up here of 2-year overall survival at this point can easily be reached with any of those treatment options. Of course, we have a track record of a couple of million patients that we have transplanted. We don't have that for the gene editing approaches or gene therapy approaches. And I think there are several other issues that we need to consider, and I think that we can also discuss here on the podium who to enroll where and what to expect from which patient, from which treatment option. In conclusion, I think that a transplant, next to the safety that we can apply right now, is a very solid and very easily applicable tool to treat patients with hemoglobinopathies. Matched sibling donor being the standard of care, I think we might see a better outcome doing haplotransplants, in particular with regard to the incidence of GVHD when these patients are getting beyond 15 years or 16 years of age. In the TDTs, we have to consider that we need to downstage them prior to transplant, and I think the iron overload of the liver per se should not be your marker for toxicity or severity, but rather really do a liver biopsy in these patients. We see that it is an epigenetic phenomenon, again, that the response of the individual patient to the iron overload is the more important marker. So if you see more inflammation, you might have more problems with regard to VOD during the transplant period, and iron per se is not the best predictive marker here. Age is a significant risk factor for the sickle patients, and here we need to really consider that the post-transplant complications in these patients are quite massive, and I only can encourage you to take these patients to transplant as early as possible. Alpha-beta depleted transplantation, I like it because I can control very cleanly the T-cell amount that's coming into the body. I don't have to rely on the post-Cy approach. There might be some unmasking or neoantigen inflammation-induced changes of the antigen, so GVHDs, I think, cannot really be completely avoided, but I think it's in the eye of the beholder which regimen or which treatment option you're acquainted to, you go with that. We have a curative approach that is, let's say at the moment, comparable to a matched sibling donor transplantation. Of course, little to no chronic GVHD, and I think this is very important for our patients with non-malignant diseases. And I would rather say that we can challenge the classical donor hierarchy, leave out the mud transplant and go straight to a haplotransplant if a suitable matched sibling donor is not available. And if I could, I probably would go for a haplotransplant even instead of a matched sibling donor transplantation to avoid this still persistent risk of GVHD here. So I think there's no rationale left to consider a curative option as a last possible resort in hemoglobinopathies, but rather take these patients together with the hematology colleagues, take them to transplant as early, or consider it at least as early as possible, because I think the outcomes can be extremely good. Thank you so much. Matt.
Do you have any data on fertility using the conditioning regimen you have?
Yeah, I think fertility is an important issue. I mean, we have, the follow-up is too short for this small sample size, but we have already 2 females who got pregnant post-transplant. So that's, of course, anecdotal. But I think we have some data from Maura Faracci, who published a series on triosulfan, and I think we will see that there is a superiority in fertility. Of course, we have to consider that sickle cell disease per se is an infertility-causing disease, and that makes it a little difficult.
Selim, we have an online question. Is the lower graft failure on alpha-beta deplete platforms likely due to higher cell dose rather than the regimen?
That's a very, very good question. I think our philosophical approach is that it's not the conditioning per se, it's really the interplay between the conditioning and the post-transplant immunosuppression you use. We do not see any hyperacute graft rejection in our patients since we check for donor-specific antibodies. I think that's an important part. All the other drops in chimerism are mostly related to, for example, viral reactivation. And when you understand what is going on there, and you can do that by combining your chimerism with a really obligatory split chimerism analysis. In almost all patients, you will see that they have a 100% myeloid engraftment there, and you still have a reduction of the T cells. And mostly, in particular when there's viral reactivation, these T cells are autologous virus-specific T cells. So they're basically adding up. It's not you're losing your graft, you have a top-up with autologous T cells. And you can be comfortable. You just add some antivirals. You reduce we start with the MMF because we have seen that the MMF is the drug that is important with viral reactivation. And if you slowly weaning your immunosuppression post-transplant, checking your chimerism, you will see that you have a very, very solid tool of not losing your graft, still getting rid of your viral infection, and have this high level of chimerism that you achieve with this long post-transplant immunosuppression.
I think that's a really interesting point, talking about the mix in T-cell chimerism. And if you do see that, is there a point where you become concerned? If you have good myeloid chimerism, I mean, typically you're seeing 90+% myeloid chimerism, I expect, as what we see in the matched sibling donor setting. Actually
not, because as I said, I mean, if you lose your graft within a week and it's gone. There's nothing you can do. Just, retransplant the patient, period. Don't futz around with DLIs or anything, just don't do it. You have made a mistake prior to your transplant, picked the wrong donor or whatever. So that's not the issue here. In the alpha-beta depleted setting, the immunosuppression is there to protect your naive T cells to recover. And when that is done, you can stop your immunosuppression. What we do is, even in the setting where there's no viral reactivation, when we start to wean the immunosuppression and the chimerism drops, we just go back. And the chimerism rises again, and you start the same thing, same game 2 or 3 weeks later. So it's a very controlled setting, and no need for any hassle or stopping immunosuppression. I'm saying it's a paradoxical reaction because in leukemias you have a mixed chimerism, you stop immunosuppression, dump in your DLIs and whatever, and that is not the right thing to do here. So you have to consider a different approach, and you can do it slowly and easily because there's no need for it. And also, I think it's important to understand that the sickle and thal patients are patients who have who came in immunocompetent into the transplant. So their viral load, even if you cannot measure it in the blood, in the tissue and in the lymph nodes, is much higher in patients with SCID or with leukemia. So their chance of viral disease is significantly lower than in those diseases. So that's also something that can keep you calm. And if you stay away from the infants, and there's no need to do a transplant in a TAL or sickle infant, you stay away from the adenovirus infections, right? So beyond 2 to 3 years, mostly you're safe from that as well. And that I think is an approach. And we have seen no adenovirus reactivation in our patients at all. So maybe we're lucky, but...
So just a quick question. Your matched sibling, I'm sure that's not done with TCR, alpha beta depletion. It's just a standard bone marrow infusion.
Yeah.
Yet you're giving ATG right on top of the infusion. Is that, new data would suggest that maybe you should either move that back or eliminate it. Any comment on that?
You mean because why are we adding
Because you'll get
ATG?
quicker immune reconstitution and you don't have a high risk of GVHD in this setting. And so I'm just curious. If thinking about kind of more modern approaches to ATG, whether that's the right positioning of the graft lung.
Well, I think we have not thought much about the positioning of the ATG in the matched sibling settings. Just, as I said, that's a classical.
Because it's been working for a long time.
Yeah. And so, I mean, you have seen the results are so good that at the moment we don't need to change.
It's hard to argue with success, but you might get faster immune reconstitution if you.
You might get that, as I said, but since we are not suffering from the need to change something, we're happy with that. And in the end, since it's in a trial, it's good that's in a trial, but it's also bad that it's in a trial because every change is a tremendous workload to amend the protocol.
Selim, thank you for that excellent
Thank
talk.
you so much.
I will next introduce Josu de la Fuente, a consultant hematologist, professor of practice at Imperial College London Healthcare, NHS Trust, and Imperial College London, United Kingdom. And he will take an alternative approach and talk about post-transplant cyclophosphamide as a platform enabling universal transplant in hemoglobinopathies.
Well, thank you very much for the invitation, and you can probably feel my trepidation by giving a non-alpha beta depleted talk here. I wish to reassure you that alpha beta depletion is actually the approach of choice in my institution for inherited bone marrow failure syndromes. But there you are. I also felt slightly reassured by seeing that Selim had to use one of our slides in his presentation. So I'll play a compliment back in the conclusions by using alpha beta depletion as the standard for GVHD. So those are my disclosures. Now, it was, of course, when we're talking about PTCy, we're talking about the backbone that Johns Hopkins developed. But it was of great joy to me to discover that the original work in my xenografts demonstrating that cyclophosphamide was able to preserve the viability was actually done at my hospital at St. Mary's in the 1960s. Now, Leo Lusnik has never acknowledged to me that he read this paper, but it's difficult to escape that that was the first publication of PTCy. So you all know that, of course, there is a different aldehyde dehydrogenase content in stem cells and T cells that allows the deletion, and that in addition, cyclophosphamide given day 3, day 4 post-graft allows the Treg pathway to be enhanced. And so we have a situation where we preserve the stem cells, whereas we delete those whole T cells which are alloreactive and encourage those which are not onto a peripheral tolerance path. Now, the work that Selim summarized and that I'm going to give you a history as to how we reached was actually done not just by me, but by the entire Vanderbilt Global Haploidentical Learning Collaborative. And what we mean by that is a group of people. Initially, you can see on the left-hand side, we met in 2013 in my hospital at St. Mary's, where we initiated this work, and you see Brodsky is there in the middle, but we have Adetola, Kasim, and Debaun, and a French group, which then went and did their own work. And then on the right-hand side, you can see the more modern version of the group with enhanced, including people like Ravi Hanna and Irfan Noor, Michael Ekritz, and people from Brazil and India. And Kenneth Cook is also there in the middle. So I acknowledge them all because this is the work of all of us. Now, what we wanted to do is that taking the Johns Hopkins backbone that shown the feasibility of delivering haploidentical transplantation in hemoglobinopathies, but which had a very high risk of rejection. We were trying to see how we could preserve that reduced intensity approach, which we thought would be very important long-term for the care of our patients. Whereas if we were to add additional components, we might be able to reverse that problem of engraftment. And eventually this finished in adding thiotepa to the conditioning regimen and adopting a preconditioning approach, which for adults consists of hydroxycamide or hydroxyurea only, but in children is both hypertransfusions and hydroxycamide. Now, the initial work was actually wider. We divide the patients in 3 different strategies. Group A was more or less trying to replicate the work of Johns Hopkins, and as it happens when you replicate it, you get the same results. And so we got 40% rejection, and we stopped very quickly. And this was done within, so what we mean by a learning collaborative is that all the institutions had the same protocol. We had very clear stopping rules, and we were meeting on a weekly basis to act uniformly and to identify problems quickly without the constraints of a proper phase 2 trial that it would have been impossible to be adopted across so many institutions. So we quickly drop just replicating the initial backbone, and then we have a situation where, from what we had learned from the historical management of thalassemia, we knew that thiotepa had been instrumental as an agent, particularly in very young children, to prevent rejection, and that preconditioning with the use of hydroxycamide and azathioprine at that point, had resolved the problems of rejection in difficult thalassemia patients. And whilst using azathioprine and hydroxycamide didn't lead to rejection, to primary graft failure, there was a big problem with macrophage activation syndrome. You can see that the 1-year overall survival was only 83%, due to the fact probably that the azathioprine was leading to anergy and the PTCy not doing the job that was supposed to do. Whereas adding thiotepa and long, which is group B in the middle, seem to have resolved the problem of rejection with an overall survival, and that is what led the basis of the CTN 1507 trial, and in France, the Depleted Haploidentical trial. Now, this is the work of the initial 15 patients that we did, and that demonstrated that adding thiotepa without any preconditioning led to very good overall survival, with a disease-free survival of 93% and an incidence of acute GVHD of 17%, which seemed very acceptable for a haplo setting. And so we widened this onto multiple sites, which is what we presented in ASH 2020. And you can see that we had 41 patients across 22 different sites, with 93% patient engraftment, still maintaining our very initial data, with respectable rates of graft-versus disease. You can see grade 3, grade 4 was 9.7%, and moderate or severe chronic GVHD was 17%. And we could see no association between GVHD and whether we have used bone marrow, what the cell dose was either in relation to total nuclear cells, CD34 or CD3 cell dose. Now, what we hadn't noticed at that point is that this population, although included both children and adults, it was very skewed towards late adolescents and young adults. And so when we updated the data presented in ASH 2022 is when we realized that there was a very substantial difference in the incidence of primary and secondary graft failure between children and adults. The overall survival was good. You can see that the transplant rate and mortality was around 5% for both children and adults, but you can see that there was a 16% risk of secondary graft failure and 10% risk of primary graft failure in the pediatric population, whilst maintaining good rates of graft-versus disease. And so if we look in greater detail, you can see that all graft failure occurred in children less than 18 years of age, that we had 4 incidents of primary graft failure and 6 incidents of secondary graft failure. And so that led us to reconsider the preconditioning approach that we had dismissed when we initially were getting excellent results. And so the final work of the Learning Collaborative is under review for blood, we have submitted eventually 70 patients that fulfill all the criteria of following the protocol, of which 62 have had a successful engraftment, and where 5 patients died. And you can see that both in the pediatric and the adult cohort, we have comparable 1 year and 2 year overall survival. Now, the rates of grade 3, grade 4 GVHD are 10%, and there's no difference by age, unlike what Selim was demonstrating. And the 2-year incidence of severe to moderate to severe chronic GVHD was also 10%. And here we did see a significant difference between children and adults, and so I'll show you later how we are approaching this. However, the whole cohort does continue to demonstrate the very significant difference in the event-free survival between the pediatric and the adult cohort, with 11% of the pediatric subjects having had graft failure. Now, if you have good engraftment, then the reality is that you maintain very high levels of chimerism, both in whole blood and T cells, as you can see there. And so, as I was saying before, parallel to the work of the Learning Collaborative, which gives us a degree of flexibility to adopt new measures to tackle problems, we have had the phase 2 single-arm 1507 protocol that was presented at us this year. See the eligibility criteria there, including acute chest syndromes, vaso-occlusive crisis, and receiving transfusions for sickle-related complications. The study transplanted 42 patients with completed follow-up of 38 patients, but we have analyzed the 42 patients that were transplanted, whether they were withdrawn, lost to follow-up, or actually continuing the study. And you can see on the left-hand side the patient demographics. And here you can see the characteristics. These are patients who are older than 16 years of age, and whom 2/3 of the cases had vaso-occlusive crisis, but there is a very significant burden of cerebrovascular disease, with 14% of the patients having had a stroke and 38% of the patients having chronic red cell transfusions, many of them because of cerebrovascular disease. And so the study did meet the endpoints. It had been statistically designed so that we had an event-free survival of more than 85%, and indeed the 2-year event-free survival was 88%, with an overall survival of 95%. And you can see that on day 28, approximately 5% of the patients had a primary graft failure, but the vast majority achieved good engraftment. And so looking at the acute and chronic GVHD, you can see the acute GVHD on the left-hand side and the chronic on the right-hand side. And so grade 2 to 4 was 26%, but grade 3 to 4 was only 4.8%. And the cumulative incidence of 2-year chronic GVHD rate was 22.4%. But importantly, grade 4 did not appear in the acute GVHD analysis, and only 7% of the patients had severe chronic GVHD. So going back to the pediatric arm, which is of course what is of most interest to this group, we had already started at St. Mary's analyzing the patients who not only were receiving thiotepa, but had preconditioning by maintaining the hemoglobin level above 110 for at least 8 weeks pre-transplantation and using hydroxycarbamide. So we presented this in EBMT in 2022, and you see that this seems to abrogate the risk of graft failure, with the only patient who had died doing so on day plus 361, and a time when the patient was well engrafted with good donor chimerism and data, not GVHD, but unfortunately was not on adequate pneumococcal prophylaxis and died of sepsis in a small local hospital where this was not recognized. Had not been so, we would have had 100% overall survival and disease-free survival. And you have the chimerism data there. Now, building on that, working within the Learning Collaborative, we have now accrued 26 patients who have had preconditioning with hypertransfusions and hydroxycarbamide in addition to thiotepa. And there has only been 1 case of transplant-related mortality and 1 case of graft failure, with a median age of 12.4, as you can see there. So these are patients between 2 and 16 years of age, so capturing that cohort of patients where we were seeing both primary and secondary graft failure. The acute GVHD rate 2 to 4 was 30%, but only 11% of the patients have grade 3, grade 4, with only 3.8%, only 1 patient having grade 4. And if we concentrate on chronic GVHD, you can see that there was only 1 case of severe GVHD, with only 15% of the patients having moderate to severe GVHD. That gives us an overall survival and disease-free survival, as you can see on those curves. So figures which are equivalent to what the BMT CTN study shows for the adults. And so it seems, although I appreciate that it's only 26 patients and we are now going to accrue more sites in a prospective manner, but it seems that the early problem of primary and secondary graft failure is resolved. PTCy plus preconditioning does enable us to have very high levels of donor chimerism data. And so what I'm trying to show you in that graph is that there is one patient that very early on lost a graft, and there is a second patient in orange that we are stabilizing. But you can see that the vast majority of the patients are having high levels of donor hematopoiesis. So the resolution to those levels, which I think they are reasonable in a haplo setting, but clearly not quite as good as alpha-beta depletion, comes in the form of a Batteset in our view. And so building on the work that Sarita Jaiswal has done in India, where she added a Batteset to 10 patients with both sickle and thalassemia on a PTCy backbone where there was not acute or chronic GVHD. We have adopted this in our group, and the data we have is very early, and I appreciate that only a proportion of these patients have mismatches. So we are not mature enough in the follow-up to be able to give you haplo-specific data, but the early data does seem to replicate what Sarita Jaiswal and her group have presented. You can see that in 18 patients, we have had no events with risk of acute GVHD, with no risk of acute GVHD, and only a small risk of mild or moderate GVHD, and no one with severe GVHD. Now, what about thalassemia? So thalassemia is being more complex. This is work that particularly has involved Ken Cook, Ravi Khanna, and our center, with a couple of patients from Vanderbilt. And there we are studying whether the addition of thiotepa or the addition of TBI at a higher dose of 400 is the way forward to reduce the graft failure rate. And you can see that at the moment, none of them seem ideal, although possibly the TBI 400 centigrades offers a better or a trend towards better outcomes, both in overall survival and disease-free survival. And so looking around as to what other groups worldwide are doing, it is actually the use of pre-transplant immunosuppression that is probably giving us the answer. And so for those of you who are not familiar, this comes from work both in India and in Thailand, where they use cycles of dexamethasone and fludarabine or fludarabine and cyclophosphamide, 2 months and 1 month pre-transplantation, just given for 5 days in order to abolish graft failure rate. And this is the work done by the Thai group, where you can see an excellent 3-year overall and event-free survival. And so we have done now a small number of thalassemia patients with PTCy using this approach, and we are not seeing any risk of graft failure. So in summary, I hope I've been able to show you that PTCy haploidentical transplantation is feasible, that allows a long-term cure to reach the majority of the patients that need it. This is a very important point to us, that there are not technical limitations or high-cost interventions, and so that this can be exported to places where they may not have the same degree of technology that we have. That PTCy allows us to do haploidentical transplantation with a reduction in conditioning intensity in a way that at the moment other approaches like alpha-beta depletion don't allow, and may be that we see later on a reduction in late effects. I don't know. Now, paradoxically, the most challenging group of patients has been the children, and that comes against everything that we have known in conventional transplantation from the registries, where the younger you are, the better the outcomes. But I think the use of preconditioning in sickle cell disease and PTIS in thalassemia has resolved these issues, and that we now have I think, early data suggesting that abatacept is able to abrogate the grade 3, grade 4 acute GVHD risk and extensive or severe chronic GVHD risk in a way that PTCy now is giving us comparable levels to ex vivo graft manipulation. So thank you very much.
Josu, thank you. It's exciting because now we need to figure out how to compare approaches, how we should start transplanting individuals with a new graft. I do have one question if other people are maybe thinking of their questions. And you may not have the answer for this, but abatacept is a very interesting concept for transplanters who are transplanting sickle cell disease. Is there a particular reason why you think that in sickle cell disease this is more important than in other, or is it something that it caught on, I think, with one of our transplant approaches with matched sibling and unrelated donors? But do you have a thought about that?
So in my institution, we only do transplants for non-malignant conditions. So we only, and they have to be red cell somehow, red cell type disorders. So we only do bone marrow failure, aplastic anemia, and hemoglobinopathies. And we now have adopted abatacept across the board, except for the alpha-beta depleted transplants. And the reason why we have done so is because it is an FDA-approved product, which clearly is not toxic and does minimize the chances of graft-versus disease, which all the long-term studies clearly showed that is what leads to hemoglobinopathy patients not to reach normal quality of life. And I think it's early days, but so far the signal is that it is favorable.
I'll add another question since everyone is running to the microphones. For your concept of preconditioning versus the pre-transplant immune suppression, can you kind of clarify a little bit more how that's different? Because I think it's very special or very different in thalassemia in particular, and sickle cell disease for the preconditioning you're discussing, which is a fairly new concept.
So the preconditioning in sickle cell disease aims to suppress the endogenous hemopoiesis, which is obviously very active in these conditions. So we use hydroxyurea we do it in trying to achieve the maximal tolerated dose, in the same way that you will do in a conventional sickle care patient. Although if they haven't been exposed to hydroxyurea before we go to the top end of 30 milligrams per kilogram. And so the idea is to try to reduce to the maximum the cellularity of the patient. Whereas in the thalassemia population, the aim is to create immunosuppression. And initially this work came from the fact that, of course, in many of these countries there is no access to leukodepleted products, and they had many cases, not just of DSA, but also red cell alloantibodies and maybe general alloimmunization. But they then appreciated that it wasn't just a matter of reducing these antibodies, but actually did enable engraftment.
Anant from Children's National Hospital, Washington, D.C. I had a question in terms of abatacept. We talk so much about abatacept in view of GVHD prevention, but can it suppress the recipient T cells if used pre-transplantation so that we have something functional suppression along with the ATG that is actually cytolytic for T cells?
So it is likely that it does, but at this moment we only have a perception rather than real data. Our sibling approach for both sickle and thalassemia is an FTT approach, exactly the one Selim was showing you before, but we do get very high rates of mixed chimerism. Now it is a stable mixed chimerism, but we have had a small proportion of unstable mixed chimerism that have resulted in clonal evolution in the way that it has been described in the literature. And we have seen that both in thalassemia and sickle cell disease. So when we adopted abatacept, we adopted it across all the transplants, partly because we wanted to have 0 rates of GVHD, but partly because we are hoping to see a reduction in mixed chimerism and greater stability of the grafts.
Thank you.
Thank you, Josu. Alicia.
No, I have a question actually for both Josu and Selim. I have to say I'm very impressed by this data. It is really cool for me to see so amazing data across the board for patients with hemoglobinopathies, especially when treated early. I really share the message of treating them early, and in this country it has been harder to treat them earlier, and I think this must be a goal for us as a physician scientists to really give them access to treatment before they become too compromised. One question about the graft rejection was which threshold of or MFI for the donor-specific antibodies are you using? I mean, these patients are more or less all sensitized, and if you have a specific treatment that have been effective in reducing their levels before the conditioning regimen. And then for the post-transplant side, I was really thinking, like, I think that you tackle pretty well the graft rejection portion. I mean, there is a certain risk of graft rejection which we are never going to make 0 because it's just part of the disease and it's part of doing transplant, right? I mean, it happened with other indications as well. But I think that already the changes made over time really made the approach safer. I'm still not happy in seeing that chronic GVHD being, especially in the sickle cell population, no lower than 10%. And I know with the alpha-beta depleted that even when we have a small incidence of chronic GVHD, it's really clinically irrelevant because it's mostly nail dystrophia or like small areas of dry skin. So even if it's not impacting on the quality of life. So I want to maybe you to comment a little bit more on that, if you think that the abatacept is going to take care of that too, or what are the next steps?
Yeah, so that is, so I'll start if you don't mind, Sally. Yeah, that is exactly the hope. I mean, the early data does appear to show that, but of course we need to accrue a larger number of patients. Now, from the patient's point of view, we don't have anyone who has required treatment for chronic GVHD beyond 18 months. So that, as a background, I think it is quite important. But it does undoubtedly make the transplant process complex for a proportion of patients. So I agree with you. I am not happy even with 8-10%. I think, the aim is to have no severe chronic GVHD. And so that's the reason why we were so drawn to the attention of the abatacept data, where it does seem to be a bolus. And both the data of the Indian group of Sarita Jeswal and our early data seems to support that, but time will tell. And if that is the case, then of course we'll have an approach which is still fairly inexpensive. Abatacept is not expensive, and will allow us to maintain this minimally intensive protocol, which we hope will be able to export anywhere. In relation to the DSA, so quite a significant proportion of those patients that you have seen in my slides had significant DSAs, as high as MFIs of 20,000-25,000. The UK, I mean, to start with, some of these patients were from different parts of the world, but even in the UK, we are no longer dealing with patients whom settled in the 60s as a remnant of the British Empire. These days, we have as much immigration as anyone else, and the majority of the patients we transplant are, well, I have to say, it all depends where there is trouble in the world, from Afghanistan, from Syria, from Central Africa, from the Democratic Republic of Congo. And they've been exposed to blood products in a non-standardized way. So we use the Johns Hopkins approach of plasmapheresis with immunosuppression of tacrolimus and MMF. And it has worked very well in everyone but one patient. And looking back, we probably will be more assiduous in delaying a graft if we don't achieve an MF5 of less than 2,000 and maybe adding bortezomib to that particular patient. In the patients with thalassemia, it's a lot easier because the 2 rounds of PTCy, day 60, day 30, or around there, allows you sequential testing. And so if the PTCy on its own is not sufficient, then you still have the possibility of doing the plasmapheresis or adding bortezomib. But we don't exclude in any way people with DSA, because I think there is a feasible approach of dealing with it.
So again, to be a little bit different, I am planning a roundtable discussion. And so I will ask again for Josu and for Selim to come on up here, have a seat. And then I will ask Bindu Sathi, who is Associate Clinical Professor at UCSF Fresno Program, Valley Children's Hospital, as a hematologist, hematology representation. So I'm excited to hear what she has to say, as well as Dr. Matthew Porteus. He is here from Stanford. He's already, there's no introduction. Do I need to? But Dr. Porteus will represent, I think, a transplant as well as gene therapy point of view. And I think in all of the presentations, there has been an indication that transplant has been somewhat limiting for individuals with sickle cell disease and thalassemia. And I think as transplanters, we have tried to kind of grow the donor field, grow the opportunity and for transplant. And that's been met, I think, at least in the United States, with some resistance for various reasons. And so as we've talked about the success with haploidentical transplant, we're early in that success, but what I'd like for us to do as a group is talk about who we should consider for haploidentical transplant, and especially in this era of gene therapies becoming now FDA approved for both thalassemia and TDT, or sorry, for sickle cell disease. So I think I was going to put Bindu on the spot first. From a hematologist perspective, in individuals who don't have an immediate threat to life, where the life expectancy can be multiple, even generations, or decades, not generations, how do you approach, or how do you think we should be approaching referrals for transplant, especially as we're thinking about the younger patients doing better with transplant, who may have a long-term benefit if transplanted earlier?
Right. I think this is a very tricky question. Like, we deal with it on a day-to-day basis in our sickle cell clinic. First and foremost, even before going into haploidentical transplantation, we have to really identify the correct kind of sickle cell patient who might be eligible for transplantation. One of the things that we are finding out is, even though it is a single point mutation, there is significant heterogeneity as far as the symptoms are concerned and the severity of the disease is concerned. There is definitely, cases where there are very severe disease with stroke and the classic stroke requirements for chronic transfusions, alloimmunization, significant alloimmunization, which makes it tricky to continue chronic transfusion therapy in some of these patients. Pulmonary hypertension, severe osteonecrosis, priapism, sickle lung disease, sickle hepatic disease, sickle renal disease. All these makes it severe phenotype. But then we do see about 30 to 40% of the patients with the same mutation, due to epigenetic changes or haplotype changes, they don't have severe disease and they do really well. And there's also a subset of our population that we see with hereditary persistence of fetal hemoglobin along with sickle cell disease who doesn't have any disease at all and probably behave more like a sickle cell trait. So to really like say that they are upfront eligible for transplantation is difficult as a clinician for me to make that recommendation. I have to see this whole phenotype of the patient before recommending, even before going to haploidentical transplantation, whether they are even eligible, they should be going into transplantation. Especially with the hydroxyurea data that is coming up. We have significantly great response with hydroxyurea, especially if you can escalate it to maximum tolerated doses, and they're doing well with that. And I wouldn't say we have enough data with the newer agents, the FDA-approved disease-modifying agents, but I would say definitely hydroxyurea, maximum tolerated doses, they're doing really well, compliant with medication. It's going to be tricky to say that they should be upfront going into haploidentical transplantation.
How about transplantation? Let's say you have a sibling donor available. How about that?
Yeah, that is something that we would probably recommend if they have a matched sibling donor percent.
They have the same risk, right?
Younger patients, yeah, we do recommend that, especially if they fall into the severe phenotypic criteria. If not, it's going to be a little bit more of a harder sell for the families to accept it because of the risk of infertility, because it's not a negligible risk. There are concerns within the sickle cell community about the downstream malignancy risk. Again, you cannot, it's negligible, but still it's not zero. So those are the things that parents usually present to us when we talk about, like, you need to go for transplantation. But it's an easier sell, that option is an easier sell for these patients when they have severe disease and the phenotype is severe.
Yeah. So, agree, except I'll push back a little bit. The patients who are, quote, doing well are doing well until they're not. And that can happen quickly, and it often doesn't happen when they're less than 18 years of age. And so how do you assess that possibility that they're doing fine, good response to hydroxyurea, 20%, get through 18, transition out of your practice, and at age 25, their response to hydroxyurea for whatever goes down, and then they have a stroke. And now you're too late.
Yeah. So we do have, we do have multiple discussions with the families. And again, the families have a big role in this and this decision-making process. Many a times I have had families and parents coming and telling us that if they are doing quite well, like if the boy is doing quite well, we would want the patient to be participating in the decision-making process, which is around till 16 or 18 years of age, when they say, I can take that infertility risk, I can become infertile, but I don't want to deal with the disease anymore, and I want to go for transplantation. But many of our patients' parents are hesitant to, especially if they're doing well, to make that decision earlier up front, saying that, okay, go ahead with the transplantation. But we have very motivated parents seeing all the data that everyone is presenting. And this is not haploidentical transplantation. It's just matched sibling transplantation. They are compelled to go ahead with matched sibling transplantation.
The only problem is that once you approach transplantation around that age, you are no longer providing a cure. You are arresting any further progression, but you have a patient who has organ damage. And so the difficulty with what you are expressing, which is of course what all of us have to face in the clinic, and I'm very sympathetic, is that at the time where you want to cure the disease before there is organ damage, it means that you need to tackle this condition probably below the age of 6. And so there is very clear data from both in thalassemia and sickle cell disease. If you take thalassemia, by the time you have been on transfusions for 20, 25 years, 90% of the patients have one end organ damage. Many of them will have multiple end organ damage. If you look at the patients with sickle cell disease, as pediatricians, we feel fantastic because we have abolished the infancy death rate with infections. We have reduced childhood mortality with transfusions and hydroxyurea. But the reality is that we have not moved a single month in the extension of their life once they get into the 30s and 40s and 50s, if majority of them don't make it to that, and that they have an adulthood with severe end organ damage. And so it is challenging, but I think one should say that you need to offer the best possible curative treatment at the best possible time, and that means tackling this in childhood.
Yeah.
I'm gonna pivot a little. Well, Selim, if you want to go, I did want to ask eventually this concept of cure, which I think can then incorporate Matt into this a bit more as well. But please feel free.
Now, I think for me the most challenging population is what I call the MDS-like phenotype, which is that you tell the patient you have to go for transplant because they have like an MDS-like clone with some anemia. The patient is happy as a clam. And the parents say, no, I don't want to take the patient for transplant after you consented me that my child can die, can develop GVHD and so on. And we have a similar situation in sickle cell disease. The most difficult for me is the patient with nephropathy. They have hypostenuria, they have beginning mild proteinuria. And what are you going to tell them? He had never had a single vaso-occlusive crisis with that regard, no pain crisis, no nothing. But we had two SIBs coming in from Ghana. They had nothing, and I was doing the history and everything up and down. And when she walks out, she tells me, the only thing that is really annoying me at age 8, they started with enuresis, and I'm like, oh my God, I forgot that. So they had no other complications. But then, the year later, they developed some proteinuria and so on and so forth. And eventually, at age 12, with some massive proteinuria and progressive nephropathy, still no classical sickle crisis. They eventually were forced by the pediatrician to come to us to get transplant. And this is really the tough population. And another lady who went through the classical sickle crisis came to Regensburg to one of those educational meetings where one of our colleagues told about sickle nephropathy and so on and so forth. And she was at age 28 then. She said, I have no sickle crisis for the last 6 years. I'm on hydroxyurea. Yes, I have proteinuria, but I'm doing fine. She was some high-ranking PricewaterhouseCoopers, manager and accountant. And imagine in this really chauvinistic environment, 95% are male. She was performing excellent with a hemoglobin level of 8. And 3 years later, she came with an almost renal failure. Again, forced by her physician, and then we transplanted her, and she's now the most obnoxious person at PricewaterhouseCoopers with a hemoglobin level of 12. She's like outbeating everybody, and she's happy as a clam. But these other situations are very difficult to tackle when you have nothing but an invisible disease that is progressing, that is not hurting the patients. And then you tell them, oh, you can get VOD, you can die, you can chronic, they're out the door the next moment. And this is, I don't know how to educate them.
This is a real life kind of situation that we are all dealing with, and we don't have perfect answers. And I don't think we have done studies where we are comparing the best standard of care treatment versus early transplantation and longitudinally following up those patients.
But what Josu's saying is really right. We have two diseases. We have the early classical textbook sickle cell disease, and I think we have this chronic systemic vasculopathy that I think is comparable to a renal transplant, where you cannot really solve rejection that's occurring on the vascular level in the long run. So after 10, 15 years, the organ is gone. And I think the same is happening here. Even with the best supportive care, anything you take, you will lose these patients with irreversible organ damage at age 40, 50, or even 60. And that 60 is no age for a normal human being to succumb to anything. And I think that is something that we will not be able to solve. And there are two challenges for me right now. One is, and that's what we're working on, to identify a sensitive predictive marker of endothelial irritation. Because I think that is something that will tell you how much a gene editing approach with more than 50% of persistence of hemoglobin S is still affecting the endothelium to that regard that 30, 40 years down the road, they still have their chronic organ damage or not. So if you have some markers of endothelial irritation that will tell us, okay, this is curative. This is really curative also with regard to what's going on in 50 years, 40 years. that would be very important to have. And I think there is reversibility. I mean, this lady that I talked to you about with this almost renal failure, 4 years post-transplant, she has total normal renal function. And we see that Erfanur's data with the recovery of cerebral perfusion and many other organs. I think this is also important for us to understand which organ at which level is reversible, because that will tell us for the future which is really the patient who needs to be taken for transplant now, and which can be delayed, or what they can expect post-transplant.
I mean, they have already looked into some of the clinical and lab variables that is associated with severe disease and severe phenotype. And I think what the literature states is probably the dactylitis, in the first several dactylitis, in the first year of life, leukocytosis, and even to some extent, I would say thrombocytosis, significant thrombocytosis is adding into the pathophysiology of the vaso-occlusive crisis. And
But
severe hemolysis too,
very unsophisticated, isn't it? I mean, the problem of transplantation for hemoglobinopathies is actually not at the door of the transplanters, but it's at the door of the pediatricians and hematologists. We don't have something, I mean, I was jealous of the leukemic presentations where you can stratify these patients from the first week of diagnosis and know which pathway they're going to follow. Which we don't have.
That's such a great point. I think to date, phenotypic severity has been very subjective, and patients, transplanters, hemoglobinopathy, or hematologists have different views sometimes, but they're very subjective. And I think I've been speaking with people within the field and trying to figure out maybe a minimum severity scoring that we should consider. How can we create a score for sickle cell disease as we think about risk for a high-risk therapy? I think a therapy that can come with risk for mortality.
But I would encourage, I don't think there is a score. There's a occlusive phenotype that we're talking about, the classic, but then you have the endothelial hemolytic moya phenotype, which is a different type of severity. And I think you might have to have multiple scoring regimens, because this disease is not a single disease like an ALL or even thalassemia. I think
It's not uniform at all, right?
it's not uniform.
it's so
And it affects every organ.
So Matt, as you have both alpha-beta depleted wide availability, which I think everybody gets, even for the common cold as they go through the doors of Stanford, but you also have gene editing. How are you going to stratify your patients?
That's a good question for Tammy and David and Ami. So I'm going to turn it back to you. I mean, I have my opinion, but I want to hear.
Oh, I have to think about this for a bit. And I do want to, though, because we're getting short on time, I did want to bring up the concept of curative therapy and how to stratify, especially as gene therapies are becoming available. Because I think this concept of curative, we like to use the word curative, it's very curious. And this concept also of even low-level endothelial complications related to just mild hemolysis, I think is an interesting question. So I'm curious the group's thought on curative therapy, maybe how to prioritize the two, but also the thought about cure related to gene therapies at this time.
I think it is tough because you say, oh, it's an autologous transplant, easy peasy. But then you're stuck with busulfan. I mean, those who are not acquainted with treosulfan, you might not understand what I'm talking about, but it's it's black and white. It's really a huge difference. And yes, you can say it's an autologous transplant, but then take out in the field. I mean, the trial patients and the CRISPR trials all could receive defibrotide prophylaxis for TDT. Now you take a defibrotide prophylaxis patient at age 25 with a certain iron overload for a transplant using busulfan, you're going to see VOD in 30% of the patients. And if you don't really follow this preemptive early intervention, for example, as we use in the children with the transfusion platelet refractoriness, you start them 3-4 days later, they're gone. That's the issue with the busulfan. And then with the gene editing, yes, nice, but in the end, it's a surrogate treatment. So it's not, it's like we're bypassing the issue. So we have some red cells that are expressing hemoglobin F. And I don't know what's going to happen by the time we do non-chemo-based myeloablation with all the females being now fertile post-transplant and having hemoglobin F on both sides of the placenta. A new issue is emerging there, and so on and so forth. But there are many issues, so it's not black or white. I think it's really
that will benefit both, isn't it? Whether you do gene therapy or conventional treatment, we will all benefit from the small molecules that allow us to drop the chemotherapy.
But the issue
He's talking about the maternal fetal gradient of fetal hemoglobin for transfer of oxygen from the mother to the fetus, which may not happen, with the gene therapy. Some of the, numbers that I'm seeing is like 80% or 88% fetal hemoglobin is present after the gene therapy BCL11A knockdown models. So again, these are all discussion points, and we are all learning at this point. We don't know, we don't have all the answers, and that's probably the reason why we want to wait and see for a period of time, 10, 15 years, to see what it actually means. And this is what some of the patients are actually talking about too. Like, their parents are asking the same questions. What will happen? What does this mean down the line? Again, I know insertional mutagenesis is extremely low in gene therapy protocols, but they still have that big question dangling over the head. What does that mean? Will it change over time? So those are questions that they pose to us all the time, and we still don't have the answers to it. And infertility is a big one. Like, they do ask about infertility, and they ask for numbers. And
but I have a question. Do you tell them about what infertility the percentage of infertility if they don't get treatment?
And on hydroxyurea?
In hydroxyurea?
Well, we do discuss about that. When we start hydroxyurea, we talk about the oligospermia that is seen in boys, and decreased ovum production that is seen in.
But I just, look, I think that the disease, as somebody mentioned earlier today, the disease itself causes infertility. So yes, we need to solve the infertility question. And to answer Tammy's question, I think our goal is to get to 90% A with a hemoglobin of 12 in the least toxic way possible, right? And right now, haplos are getting us to 90% A or above, but the conditioning regimens and the immunosuppression and the risk of GVHD, there's room for improvement. I'd say the gene therapies aren't getting us to 90% A, they're leaving behind 60% S, and we're talking about the long-term risks of that. Slightly less toxic, but still requiring busulfan. So I think the target's up here, and we're going to maybe get there in different ways, or I hope we do.
Yeah. Before I let Jesse speak, I think there is a concept, at least as a cell therapist, of shared decision making, but also trying to understand or share or work with families in understanding opportunity cost. Because if we do a therapy now that fails and we're expecting better therapies in the future, right now you're not candidate for gene therapy. If you've had a stem cell transplant, it's hard to do a second transplant. And that's a really difficult conversation in this landscape, trying to prioritize for families. It's really a lot of shared decision making and conversation. And I'm gonna let Jesse go. This is our last comment or question because we're out of time.
I guess, sorry, I don't want to turn it into a comment because I'd be really interested to hear what you all have to say, but I guess as I'm listening to you guys talk and thinking about these difficult decisions that these patients have to make, I think another thing in the shared decision making that's very challenging is that once they leave the pediatric hematology practice, they are now young adults that go into the adult world. And it's a totally different world, right? We chase our patients down, and in the adult world, the patients are chasing the doctors down. So I just feel we have this kind of responsibility too, and it's really hard because I do think even, a 16-year-old isn't fully able to make, a decision like an adult, but it's like we have this time ticking on them. Their disease, of course, but also just kind of by the time maybe they're compliant when they're at home, but then they go to college and then, they're no longer compliant. away from home, basically. So
I think to comment on that just a little bit, we talk about the severity phenotype, but I think there's a lot of discussion, and probably more so in Europe, about healthcare deserts for individuals who don't have strong healthcare support with sickle cell disease. And is transplant upfront and early the right option, or is it a very complicated way to change their disease?
What I experience in my practice, I have about half of the patients self-referring. So they come against the opinion of their primary care physician. They say, don't tell my doctor, but I want to go for transplant. I'm like, okay. And many of those patients have their matched sibling donor sitting next to them at age whatever, 25 and 19. I'm like, what have you been waiting for? Where have you been all these years?
We never deter. Actually, this is the stem cell transplantation is an option that we always give every one of our patients with sickle cell disease as well as transfusion-dependent thalassemia, among the landscape of everything else. And probably the opportunity they don't have is to have a face-to-face immediate consultation with you guys also at the same time. But even from the get-go, when we started, we start our education on our patients around about 1 month of age when we start them on their treatment. And this is something that we consistently talk about. We talk about every new therapy that is there right now, and including hematopoietic stem cell transplantation. Haplo, we haven't talked about it much, but the option of matched sibling and matched unrelated donor transplantation. Whatever data we have discussed that. And also now there's significant interest in gene therapy protocols, especially with the FDA approval. So we want them to be very educated and reaching out to us, asking us whether they can have consultation with you regarding that. And there's significant interest in the field. But I do see them, after having the consultation, backing off after they meet you and talk to you, because they're still having questions. And also there's some social factor also that is playing a big role over here, especially in the African American community. Even COVID vaccination was difficult in that community. So to sell this and to convince them this is the way to go, it will still take many more years to reach there. It's education, of course, but it'll take some time to reach there.
So I'm wondering that as more and more of the stories are told about patients who undergo a bone marrow transplant, or particularly the gene therapies, and they describe how their lives are transformed, whether that intra-community communication is going to change this narrative. When you have now tens of patients who are describing that I'm no longer allergic to snow, I can go to work, I can pursue. When that starts hitting hundreds and thousands of patients, and you have person A over here who's saying, I'm doing okay on my hydroxyurea, but I still have pain at home, and I'm still coming to the hospital once or twice a year, and somebody else is going over here is like, I haven't seen my doctor in 5 years. I think that's going to do more selling than any of us can possibly do in terms of education.
I think that is happening. That is happening. I used to be asked in the last 3, maybe 4 years, whether I was going to see a massive reduction in the number of alternative donor transplants now that gene therapy was available. And actually, our transplant program now has a waiting list of 9 months. We've never seen this before. Because there is such increased interest in the community to have a curative therapy.
Same. That's what I meant before. It's that they're coming by themselves. They're educating each other, and they're bypassing their hematologists. So the hematologists really have to talk to us. We have to collaborate closer to really identify the population when we take them to transplant together and take them back to the hematologist post-transplant.
I'm going to go to the mic really quick.
Yeah, it was just a comment. So my name is Ghada Abusin. I'm from Michigan. So we actually have, I have 2 hats. I'm a hematologist and on Wednesdays, and then a transplanter on Thursdays. Okay, this is how our setting is. But we actually tissue type all our patients, and we tissue type their siblings when we have siblings. We save all the cords for all the babies coming up, and we offer transplant for all siblings at the age of 3. So once they turn 3, if they do have matched sibling, they are gonna go. And it's kind of like the learning and the treatment starts from the moment that we know that they have matched sib. And you start talking to the families about what does it mean. And I can tell you as a transplanter, nothing warms my heart more than having someone who's cured and doesn't really know about sickle cell other than the news of it. And one other comment about the fertility, from the experience that I have so far, nobody really cares that much. The parents worry about it, but when we talk about everything else of sickle cell, fertility comes down, especially with the advent of more therapy. I noticed that the fertility issue comes to the survivals maybe 5 years later.
Yes.
Not when we are going through the transplant itself. Now for the gene therapy, we need to be careful about calling it a cure, because this is something that we still need to see, but it's not really cure, it's not correcting, so I don't know. I'm very interested in the haplo setting because we actually had a lot of haplo post-transplant Cy in the trial, outside the trial. And one of the things, and I think this is just an observation from a clinician, the ones who did actually the most all of them did okay, but those whose donors were not actually sickle trait. And I don't know if this is just my observation through it, but my patients who had either match unrelated donor or patients who had their siblings being their haplo who did not have trait, they actually fared the best from a quality of life and from what they did afterwards. This yet to be investigated, but it comes in the choice of donor when you want to see, especially with the pain crisis, those who are coming for pain. But we don't have triosulfan, and we need to work on that.
Yes.
I think that, sorry, I know Alicia, I'd say that's a challenge to you guys to follow your patients who've now received a haplo from a trait parent. And yes, they're clearly better, but are they going to, what is their progression to nephropathy and chronic kidney disease?
I mean, in the setting of matched sibling donor, with the STAR group, we've been able to publish that there's no difference in organ function with not 20 years follow-up, but that the a donor with trait does not change outcomes. And so I'm curious if that will continue with longer follow-up.
This is a fantastic discussion, and I think it's really what we need. And while I'm hearing that, there are two things that I just wanted to challenge a little bit, because as I have been lucky enough to practice a long part of my life in Europe, and now I'm practicing here, I see what Selim was saying about if you never have used triosulfan, you don't have a sense, because one thing is reading the paper, and two is seeing the patient's bedside. And so even if we talk about matched sibling donor transplant, so really the standard of care, it is very different to offer a family a transplant with triosulfan, tiotepa, and fludarabine than a transplant busulfan flu. So that translates into that like educational portion to the family, in which it becomes harder to tell them what results are we even talking about, what are the numbers I am informing you to, because I have transplanted many patients with thalassemia and sickle, again, in Italy, and really the problems that we are discussing here were so different because the transplant rate of mortality, the toxicity, the VOD, the GHD are so much lower. And even just like fast forward today, right, if we see the slides that we have seen today at the symposium, those are much better quality of life than a transfusion dependence and occlusive crisis. So what that brings to me, one is how can we educate better this family? How, as a scientific community, how can we partner with the hematologist to bring those information right away into the families? Because one very important thing that we had in Italy, I'm sure there is in other part of Europe, were really parents' association. We were receiving calls from this family when they knew that they were pregnant, because they knew already that they were trait, they were going to have kids with thalassemia, and they wanted to transplant them as soon as possible. So they wanted to put them in the list. And all these conversations were happening between parents way before coming through pediatrician or hematologist, for example. And the other even more important point is, we need to get together, US, Europe, it's time to just get together because it doesn't make sense to me. I mean, it's a really suffering to see, triosulfan data with an alpha beta depletion and this rate of graft rejection and saying, oh, but I cannot do that tomorrow here. And that's true for other indications. And it's not just triosulfan, right? I mean, obviously, we all have a different expertise and different strength. Maybe it's time to come together, really, without looking at where we specifically work and enrolling more patients so that we can really give this outcome to more patients worldwide.
I think to add to that, Alicia, how can we, as an individual who does bone marrow transplantation for sickle cell disease and thalassemia, how do we instill trust in the community that we are responsibly offering transplantation that has a high, because I think everyone has experienced, at least who treats sickle cell disease, a catastrophic transplant in the past. And so how do we instill that confidence to collaborate together? So maybe that is where we conclude this. Thank you, everybody, so much. That was wonderful and just made my day, so I appreciate it.